stop this like by going this. Perfect. I love when that works. Good morning, everybody. Thank you so much for being here today. It's really a pleasure to welcome you all here today. I know there's a lot going on in Washington, so I am really pleased that so many of you here today to hear about our new study, and that we were actually able to bring an amazing panel of providers here to shed a spotlight on how critical women's health issues are playing out in communities across the country. This project came about because we were interested in really learning more about what's really happening on the ground in communities across the country. As many of you know, KFF tracks a wide range of policy issues and provides analysis on the impact of these policies, and we have a particular interest in focusing on low-income communities and people who are really at risk for being underserved. The Women's Health Policy Program, we have really been focusing a lot on the rapidly changing landscape in reproductive health care. As you know, the Title X program has changed significantly. The nation is now finally waking up to the fact that we have unacceptable disparities in maternal mortality and morbidity. STIs are again up on the rise. And of course, in a growing number of states and communities across the country, abortion access is disappearing, and now a new case is headed for the Supreme Court in this term. So we wanted to know what was happening on the ground in communities that often don't get a lot of attention, but in many cases really shoulder the impact of these policies and trends. Those that are medically underserved, in rural areas that are highly segregated or economically challenged. So in the beginning of the year, we undertook this study to really look at 5 different communities. We focused on family planning, including contraception and STI services, abortion and maternity care. And we focused on really those services and, for low-income women. So we picked sites also that represented different communities across the country. And let me tell you, it was not an easy choice. We were faced with a map and the whole country out there before us, and so it was really pretty interesting and quite a difficult process. But we picked 5 sites that we felt were representative. We selected Selma and Dallas County in Alabama, Erie County in Pennsylvania, St. Louis, Missouri, the Crow Reservation in Montana, and Tulare County in California's Central Valley. And while these communities varied in many ways, as you will hear from my colleague today, Usha Ranji, in a few minutes, and Usha led this amazing undertaking, there were some consistent and cross-cutting factors across, I should have moved to this earlier, that all of these communities really wrestled with. I have to admit, this has been one of the most interesting projects that I have been involved with in my long tenure at the Kaiser Family Foundation. And it would have been great to bring you all with us to all of these communities, but really to see the amazing work that folks are doing to assure that women do have access to some of the most sensitive and critical services that they will need in their lives, sometimes against very difficult odds. But I feel very fortunate that we've been able to bring some of the women's health leaders from this community to be here with us today so that you can hear directly from them about the experiences that they've had and also the experiences of the women that they serve. So first, as I mentioned, my colleague Usha Ranji, who's the Associate Director of the Women's Health Policy Program at KFF, will give us an overview of the study and highlight some of the key cross-cutting findings. And then I'm going to turn to the guest panel to have a conversation really about how women in the communities access the broad range of reproductive health services, the challenges they face, as well as their community assets and resources. We're going to reserve some time at the end for some questions from the panel. There are going to be people going around with cards, and so if you have a card, if you want a question, take a card and then kind of pass it to the end. And who's going to be collecting the cards? Michelle, I think. Yeah, will be coming around. This event is also being recorded, and so it will be up on kff.org at the end of the day, is what I'm told. In addition to this, that you each have a summary report. There is also a report of each of the sites as well. We printed some copies. We didn't print enough for everybody because we wanted to be really respectful of using paper, but everything is up on kff.org if you want to download and print a copy. So before I turn the mic over to Usha, I think a few things are in order. In addition to Usha, Michelle Long, who's over there, was the policy analyst, and they worked tirelessly on this project. It really was one of these things, as you know, where you have an idea and you sometimes don't realize like how much is going to be involved in this project, and this was really a significant undertaking. Our tiny but mighty team was assisted by our partners at HMA, and Sharon Silo-Carroll is here, is right here, and Carrie Rosenzweig, Carrie Rosenzweig went to all 5 sites, as well as Diana Roden and Rebecca Kellenberger assisted us with this project. I also want to acknowledge the contribution of our friends at Perry Undum Research and Communication. They really helped us organize the focus groups. We had focus groups of low-income women in every single one of these sites. They had a fantastic facilitators and really made the voices and the experiences of the women really come alive. And I also finally want to just acknowledge and express my and our deep appreciation to the women and the men in all of the sites who really generously shared their valuable time and expertise so that really we could get a good understanding of the work that they do in their communities. There are too many to thank here. We would fill this whole page, but we really are so grateful for their participation. So if you're watching, thank you. So with that, now I'm going to turn it over to Usha, who will get us started.
Thank you, Alina. Good morning, everyone. Thanks for being here today. So, as Alina said, we worked in partnership with the team at Health Management Associates. And at the outset, we spent some time thinking about what we wanted to study and where we wanted to go. So this included reviewing the literature, as well as talking with people who work on the front lines of healthcare in a wide range of communities about what it's like for low-income populations to obtain reproductive health services in their areas, areas with really different demographic characteristics, and how the impact of federal and state policies play out on the ground, things like Medicaid expansion, the Title X family planning program, which is undergoing a lot of changes now. And also speaking with people and learning about really promising initiatives that are underway to help address barriers. Once we identified the communities that we wanted to go to, we went to each of the 5 sites and conducted semi-structured interviews with clinicians and clinic managers, public health and policy officials, leaders at community-based organizations, and as well as health services researchers. Like Alina said, we also convened a focus group with reproductive age women in each community. And the topics we covered and focused on were wide-ranging, but we primarily focused on provision of and access to family planning services, maternity care, provider supply issues and women's interactions with providers, sex education in the community, support for individuals experiencing domestic violence, and abortion access. So just a little bit. Now, I want to tell you a little bit about each of the communities that we visited, and we went to 5 really rich, complex communities. I'm going to give you just a quick snapshot on each to give you a little flavor of what they're like, but there is much more detail and context about each of these places in the reports. So starting with Dallas County, which is part of the Black Belt region of Alabama, we spent most of our time in Selma, which is the largest town in the county. Of course, Selma is known as a landmark site of the civil rights movement and has great historical significance. Today, the population is majority African American. The region has high poverty and unemployment rates. On the healthcare front, Alabama has not expanded Medicaid under the Affordable Care Act. About 17% of adults in the area are uninsured. That's higher than the national average. The region has also experienced a number of hospital closures. In fact, there's just one hospital now in Selma that provides labor and delivery services for 7 counties in that area. We heard from many that churches are important mainstays of community life. Many have traditional beliefs about sex and reproductive health and tend to oppose abortion access. Tulare County is a large, expansive area in the Central Valley of California, which is the heart of the state's agricultural region. The majority Latinx population live in a few small towns, and more than half of reproductive age women are low income. And in what is considered generally one of the bluest states in the nation, many people that we spoke with said that this is a community that is more conservative than other parts of the state. The Tulare County region has seen spikes in STI rates among young people over the past decade. Notably, syphilis came up. California expanded Medicaid under the ACA, and as a state is generally supportive of reproductive health care access, and actually operates the nation's largest Medicaid-funded family planning program. The urban site in this study is the St. Louis region, both the city as well as neighboring St. Louis County. The region is characterized as highly segregated. In fact, research has documented pretty wide health disparities between the area's Black and white populations. In terms of the delivery system, one of the factors that drew us to St. Louis is that there are a large number of health systems that are faith-based. So we wanted to learn more about what that means for women's access to reproductive health services. The state has not expanded Medicaid under the ACA. And while the St. Louis area is considered more liberal than some other parts of the state, there are a number of state-level restrictions that affect abortion access. In fact, the one clinic in Missouri that is providing abortions now is in St. Louis. You may have heard it's been on the news quite a bit lately. There is an ongoing fight over the clinic's license status, and the outcome of that could determine if it becomes the first state in the nation without a clinic offering abortions. The Crow tribe is the largest Native American reservation in Montana. It's home to roughly 3/4 of the tribe's membership. It is governed by the Crow Tribal Council, and the Federal Indian Health Service is responsible for providing health care. But many residents also see other providers outside of IHS too. This is a low-income rural area with some residents living more than an hour's drive to the nearest provider, depending on where they are on the reservation. Crow people that we talked with in the focus groups and the interviews described some of the tribe's traditional values, including the belief that the birth of a child is considered a blessing. And it's important, I think, always to remember and recognize the history and context. The history of the Crow tribe, as with all tribes, does include a history of abuses, such as coerced sterilization of women. The history and context does affect how some in the Crow community feel about reproductive health services and trust of providers. Montana has expanded Medicaid under the ACA, which has extended Medicaid coverage to many Native Americans throughout the state. And finally, Erie County, Pennsylvania, which is in the northwest corner of the state. The city of Erie has a strong healthcare safety net that offers family planning services to low-income populations, but there are fewer providers in the county's outlying towns. The state took up Medicaid expansion in 2015 and has seen a drop in the uninsured rate since then. There's a large Catholic population, which influences the healthcare and education systems in the region. And Erie is also a refugee resettlement community that saw a sharp rise in immigrants in the first half of this decade from places like Nepal, Syria, as well as a number of African nations. These are populations that in a lot of cases are used to some very different norms when it comes to reproductive health care services, which we heard about from women and for providers trying to meet the needs of new immigrants. There's no abortion provider in Erie County, and the nearest one is at least an hour away. So that's a really quick tour of 5 very different, vibrant, interesting communities. You can see they all have some very unique characteristics, but there were also a lot of commonalities when it comes to reproductive health care access, and so I want to go through quickly the major themes that we found. Without a doubt, one of the predominant themes is the overarching impact of the social determinants of health. Women's ability to obtain, afford, prioritize reproductive health, and their own health generally is closely tied to issues like income, safety, and really just the ability to meet other essential needs. I think the quote at the top there from a health department staff member in Selma really summarizes it well. Speaking about women in the community, if they don't have food in the fridge, they will not be worrying about birth control. That's the last thing on their list. I think that all makes sense for a lot of us. I would say that basic security is part of this too. We all know that there is some strong anti-immigrant sentiment now, as well as a lot of changing rules. In Tulare County, California, women and providers in the community spoke about how that translates into people either sometimes going without healthcare services that they need, or without taking advantage of public programs that they qualify and that they would really help, like food stamps and Medicaid. We heard about work to address some of these issues, such as, again, in Tulare, Spanish-speaking health educators doing health screenings at agricultural sites and actually bringing services to people and where they are and where they work. Another primary theme was the importance of coverage, particularly Medicaid for low-income populations, both in terms for women to obtain services and for providers as a source of revenue. St. Louis and Selma are in states that have not expanded Medicaid under the ACA, so eligibility for Medicaid in those areas is pretty limited. Eligibility for the program for Medicaid is, in all states, much higher for pregnant women than for parents or adults without children, but particularly in non-expansion states, it means that there are many low-income women in these communities who really don't have coverage, or may lose it just 2 months after pregnancy, once they become mothers. And as one of our physician interviewees, you can see there, said in St. Louis, said, you can't optimize women's health care in 9 months. We heard about strategies for improving Medicaid coverage, regardless of being in an expansion state or not. These include things like eliminating pre-authorization requirements or quantity limits for contraceptive methods, which are in place in some areas. Some discuss the need to increase payment rates so that more providers participate in the program, particularly in California, where reimbursement rates have been among the lowest in the country. This is an issue we've been following at the Foundation for many years. Of course, in addition to coverage, we know that people really value and want strong relationships with providers. This is more challenging in some places than in others. I spoke a little bit about the predominance of faith-based providers in some areas. In St. Louis, we heard mixed reports about the availability of contraception at these health centers, with some women reporting they couldn't get the method that they were looking for at a faith-based hospital, but others saying that even if they couldn't get services within that system, they were referred to other providers. Another topic that we heard about from health system leaders is the challenge of recruiting and retaining providers. Like Alina said, these are all communities that are designated as medically underserved, but especially in Tulare County, in Selma, in the Crow Reservation, providers said that it can be hard to attract clinicians, and some services and hospitals in those regions have had to close. To that same point, we heard about logistical obstacles that women face when they have to travel long distances, and there aren't always public transportation options available. This theme came up a lot, sometimes without us asking, especially in more rural, expansive areas like Tulare, where there are populations living on the outskirts, pretty far from the city. To bridge some of those provider supply issues, we did hear about some use of telemedicine, for example. In Selma, there is a health program using telemedicine services to extend some supports to people living with HIV. People also said that to make this more widespread, that they need sort of more secure, stronger access to broadband if we were to be able to expand that. Sex education came up a lot too, both formal education in schools, but also more generally through raising children and messages within communities. This is a really local issue in some ways. We heard about a lot of variation between school districts, even in one region. Abstinence-based curricula are the standard in some districts, but some are using more comprehensive curriculum that educate about contraception. A few people particularly pointed out the need for stronger sex education and knowledge about sexual health, particularly when it comes to stemming the rise of sexually transmitted infections that the CDC recently reported on. And in different communities across the country, people describe some very different cultural norms and comfort about discussing sex. In more conservative areas like Selma, some said that conversations about sexuality are not routine and typical. We heard about this among the Latinx population in Tulare County as well. To help address this, one example that we learned about also in Tulare is a federally qualified health center that is using Title X family planning funds to integrate routine STI services, counseling, treatment, screenings in primary care settings, so that women and men who may go for more traditional primary care are also getting integrated information about sexual health issues. And lack of information and at times outright misinformation affect knowledge about abortion too. Abortion access was really limited in all of these communities. But interestingly, we heard from more than a few people that sometimes people actually thought it was illegal. And there were others who said they just wouldn't know where to go if they or someone that they were friends with needed an abortion. Of the communities that we visited, St. Louis, Selma, and Erie are in states with the most state-level restrictions. But I should note that stigma and its impact on abortion access was a theme across all sites, including in the Crow Reservation and Tulare, which are in states that really don't have major policy restrictions on abortion. So those are the themes that emerged from 5 pretty different communities, which really leads us to believe that they are not limited to these areas by any means. Importantly, in every place we visited, we heard about a number of initiatives underway to help meet women's needs for reproductive health care that I think can also really provide lessons for other similar areas around the country. Our panelists are here and they're going to be talking about the work that they do, and I'll give you just a quick overview. In Selma, the Rural Health Medical Program is the only federally qualified health center in the county. One of the things they're doing is really establishing partnerships with other area providers to help broaden referral relationships and streamline connections to providers for their patients. They're also in the process of renovating a mobile medical van to help fill some of those transportation and distance challenges that we heard a lot about. In the Central Valley of California, the Tulare County Domestic Violence High-Risk Team is a collaborative team with staff from various agencies in the community to help address potentially high-risk domestic violence situations. And to date, it's really one of the few examples that we know about in the western part of the country. The Spot in St. Louis is a teen-friendly, freestanding site that provides health services, mental health care, express STI testing without cost. And they also operate a school-based health center in a public high school, one of the first programs like it in the area. On the Crow Reservation, the Indian Health Service has established a maternal and child health coordinator who does patient prenatal care, intake, and education, and helps connect women to postpartum services as well, such as contraception. And in Erie, Pennsylvania expanded its Medicaid program, like I said, and since then the uninsured rate has decreased dramatically, and the state also has a pretty expansive family planning program. Those really are just highlights, snippets of what we saw and learned from this deep dive into these communities. Thankfully, we have panelists who are here who are doing all this work, and we'll be able to talk about it in a lot more detail. So I will turn it over to Alina and to our panelists. Thank you.
Do you want to come up? Just what's next here. Great. Can I close this? Great. Thank you so much, Usha. That was really quite a whirlwind tour for a really kind of enormous study. Really distilling all of these factors was quite an undertaking. I'm going to just apologize right now. I have a bad cough. I'm not going to drop dead up here, but sometimes it may sound like it, but I'm really okay. I'm just kind of struggling with some asthma, so just so you know, just ahead of time. I want to welcome this amazing panel. We are so excited to have really leaders in their communities. I think some of them don't always think about themselves as leaders, but I can assure you they are. They are working really on the front lines. I don't really like always using front lines or kind of on the ground, because I feel like we talk about front lines, like working with patients, as if it's a war. And I think that for all of our panelists here, that this is not a war, this is a labor of love. They are really working extremely hard, sometimes against really difficult odds. They are from their communities, and really have dedicated their careers to serving women there. So really, it's just such a thrill to have you all here. So I'm going to start here directly to my my right is Mrs. Cachet Smith, and she is the Chief Executive Officer of the Rural Health Medical Program that Usha mentioned, and that's a federally qualified health center in Selma, Alabama, although they have many sites, and they offer primary health care, dental, optometry, podiatry, behavioral health, mental health, and services in the Black Belt region of Alabama. There are longer bios actually in your packets as well if you'd like to. It's just kind of a snippet. Next to Cachet's Katie Meter. It's going to be a little confusing because we have two Katies. And Katie Meter is the CEO of Family Services of Tulare County in Visalia, California. The Family Services Tulare is a local nonprofit that supports more than 5,000 clients a year with the mission to help children, adults, and families heal from violence and thrive in healthy relationships. Next to her is Dr. Katie Plax. Dr. Plax focuses on improving health for youth in a number of ways. She's the co-founder of The Spot, which is the program Usha told you about, which stands for Supporting Opportunities with Teens. And that is a one-stop drop-in center for youth ages 13 to 24 that provides health services and social services free of charge in St. Louis. Susan next to her is Susan Scriven. And Susan is a family nurse practitioner at Adagio Health, which is a family planning provider in Erie, Pennsylvania. Prior to joining Adagio, she practiced as a certified nurse midwife for 30 years, and she has delivered over 3,700 babies. Wow. And then next to her is Brocade Stops Black Eagle. Brocade is a registered nurse at the Indian Health Services Crow Northern Cheyenne Hospital and the Crow Reservation in Montana. She serves as the maternal child health coordinator, performing prenatal education, providing case management, postpartum contraception, and I think a lot of other things too. And I do want to acknowledge Natalie Little Owl, who is here with us as well. She is a licensed practical nurse also at the Crow Northern Cheyenne Hospital. And she has worked at the IHS for 20 years and also has done a lot of really tremendous work in her community. So thank you all. So with that, let's get started. I thought it would be helpful in your own words if each of you could take just a few minutes, because we have a long panel here, to talk to us about your communities, your perspectives, their challenges, their strengths, and a bit about your organization and your role there. We can start with Cachet.
Good morning, everyone. It is such an honor to be here. I was not expecting this when Leanna and her team walked into my office on, I think it was a late Thursday afternoon. Yes. I actually grew up in one of the counties in my health center network in Perry County, Uniontown, Alabama. As a young girl, I did not know that I would grow up to come back home in Selma and in that Black Belt region and also contribute to my community in this capacity. Some of the same providers that started their careers when I was a young child are still there, and they're still passionate and thriving and doing that hard work to continue the community. And now they're passing the torch to me. In the Black Belt region of Alabama, we get a lot of attention for a lot of the civil rights activities that have happened over the years. But here's the thing, we're still there. The progression has not truly taken place and happened because a lot of the people and resources that leave and go explore, go to college, start their careers other places, they're often told, well, don't come back until you're established. And what happens to a state in a rural community like that, you don't grow because those talented individuals don't come back and bring the community forward. My family and I had the opportunity to come back to our hometown to do that. And we see that it's a lot of work that has to happen. And sometimes it can be overwhelming. But given the opportunity that I've been giving at Rural Health Medical Program, it is truly a labor of love. Seeing members of my family, friends that I grew up with, family still being taken care of by some of these health centers, it's just been amazing. And allowing my children, I'm a mom of 4, by the way, 8, 6, 3, and 2, for them to be able to see the work that we're doing in the community and growing up knowing that whomever they become, you still need to pay it forward and give back to your communities. It means the world to me. So as far as the health center, the services that we provide, as Alina mentioned, they can go on for days. But when I first arrived at the organization 4 years ago, it was primarily family medicine, dental, podiatry. Since then, I have developed myself into the grant writer to expand the services. So we're doing behavioral mental health, telemedicine, focusing on women's health. We are closing the gap in that women's and children's services that were not there before. Our patient base was geriatric, and we're doing a great job at that because the focus has been chronic care management, not women's health. And I figured, being a mom of 4, if you focus on attracting the women in the family and taking care of that woman, she's going to take care of the other people in her family. That's just how it works. So we have created different strategies on how to bridge the gap to the access to health care by bringing the services to where people are, to meet them where they are. So working with the county commission, probate judge, city council, the mayors, board of educations, and different local business owners to offer special programs to them so that the collaborative efforts in the community can happen has been very successful for us. We've grown from 5 health centers to 3 in 4 years, so we're a total of 8 now. And we're hoping to launch our mobile service before Thanksgiving, which will be the 9th site. And that will be the one that'll definitely go to those more satellite areas and set up services such as comprehensive eye exams, behavioral health, and women's health services.
Great.
So,
Thank you.
thank you.
Katie.
Good morning. My name is Katie Meter. I'm the CEO at Family Services of Tulare County. So we're not a health provider, but we are the largest victim service provider in our Tulare County region. Tulare County is about 4,200 square miles, going all the way up to the national park. So we are comparable to the size of Connecticut, if that gives you an understanding. And we do have more cows than people. We're about 500,000 people in our community and almost double that, I think, in cows. But we are the largest agricultural producing county in the United States. Things like dairies, nuts, citrus are pretty popular where we're from. So with that comes a large migrant community. So at any given time, they estimate we have between 40 and 60,000 undocumented migrant workers in our community, which makes providing any kind of healthcare or social service a real challenge, not just because of some of the new, well, not necessarily new, but exacerbated fears that we're seeing with regard to public charge and things like that, but just the migratory nature and seasonal work that we see makes it difficult to establish consistency with families, especially women who are working in the fields. So that's a sense of what we have going on. We are faced with rates of domestic and sexual violence that are anywhere from 25 to 50% higher than urban areas of California. And we are trying to address those in the context of a very conservative, both politically and religiously conservative community. We're more like West Texas than we are California. And so even with some of the access that California has with its social policies, we definitely see challenges in our work on the ground.
Great, thank you. Dr. Platt.
Turn this on. Thank you.
Thank
All right.
you.
It's doctor proof. Thank you all so much for coming here this morning to talk about such an important health issue. My name is Dr. Katie Plax. I'm an adolescent medicine doctor from St. Louis, Missouri. I'm going to tell you a little story. I vividly remember a day when the first significant Medicaid cuts occurred in Missouri under Governor Matt Blunt in 2005. With other advocacy organizations, I went with parents to talk about the harm of these proposed cuts. I was with a mom who was working as a home health care worker. She talked with a legislator about these cuts and what they would mean to her and her 2 kids. She was a single mom doing physically challenging work. She was trying to protect her kids' health and her own health, and she was brave enough to tell her story. The legislator, after 2 minutes, looked her straight in the eye and told her, "You made some bad choices." I have never forgotten those words. Literally, after 2 minutes, the legislator had no problem telling this mom what he thought about her life and her worth without a shred of empathy or compassion, and without acknowledging that she was sharing her opinion about what a policy change meant to her. I was and still am outraged. Now, nearly 15 years later, I think, did my young adult patients make bad choices when Missouri failed to enact Medicaid expansion such that they no longer have access to health care coverage? Did they make bad choices when the Missouri legislature passed an anti-abortion law that prevents abortion, even in the cases of a pregnancy through the crimes of rape and incest? Did they make bad choices when birth control access that was affordable became more challenging to find? Did they make bad choices when crisis pregnancy centers were allowed to be sex ed educators in schools? Did they make bad choices when trauma, child abuse, child neglect, and racism affected their access to contraception? I don't think so. I think the current systems and policy in Missouri and in our country make it harder and harder for women to get their everyday health needs met. Given what I've seen happen in Missouri, I recognized I needed a different model of care for the young people who trusted me. Eventually, the brainstorming, the community building, the pavement pounding, I also became a grant writer, would become our youth center, The Spot, supporting positive opportunities with teens. The Spot was developed to reduce barriers to a comprehensive range of services for St. Louis area youth. Among the services offered are medical and reproductive health care, HIV, STI screening and treatment, case management, mental health counseling, and psychiatry, as well as other social and prevention services. Since the Spot's founding in 2008, we've helped over 20,000 young people. This includes over 80,000 medical visits, 100,000 drop-in visits, 11,000 case management visits, and over 10,000 mental health visits. This work, as you can imagine and many of you know, is hard, but it's also incredibly joyful. Thank you.
Thank you. Susan.
Thank you. It's a real pleasure to be here, and it's also a real pleasure to know that there are people like you all doing studies that highlight what our needs in this country are. And I just don't, as a nurse practitioner in Erie, Pennsylvania, I work for Adagio Health. It's the grantee for federal and state monies for all of Western Pennsylvania and parts of West Virginia, although the office that I work in is in Erie, of the city of about 100,000 people. I feel real fortunate to work for them. When I first started working there about 12 years ago, I thought, golly, I'm doing a mission trip, and I'm getting paid a little bit. And I have my weekends and holidays off because I had been a nurse midwife for many years. So our organization draws down the money for the title grants. We see, as I explain it to my friends, I work for an organization who provides care for people who normally have difficulty accessing it. And that would be our teenagers, our college students, a large refugee population, displaced women, women who fall between the cracks, STI. We have a wonderful relationship with our county health department so that we actually act as an extension of them to provide STI testing and treatment. And we have just recently gone into offering PrEP for HIV prophylaxis. We are working real hard to make our LGBTQ and transgender community feel very comfortable. They definitely have more difficulty accessing respectful and comprehensive care. So we are trying to do that. We do have some challenges. Getting the word out there is difficult, especially for the teens. We used to be in the Erie city schools, and now for quite a few years we haven't. That way we had a direct referral system into our office, and we'd often have 15 teens drop in. And now they dribble in. That's a difficulty. Also, the group of women who fall between the cracks, they may have commercial insurance. Their deductibles are so high that, and their insurance may not cover certain things like diagnostic mammograms. If they find out about it, they're so grateful because we can follow up and provide those diagnostic mammograms and get them quickly into the medical assistance program, even if they do have other insurance. So that's a difficulty. Transportation in our community can be difficult, even though it's urban. When we have a fairly good bus system, that bus system is often unreliable. Our community also is a little fickle when it comes to keeping appointments. Anything, whether it's good weather, bad weather, the first, week of school, holidays, we have over a 30% no-show, no-call rate. And that makes scheduling difficult. It makes it, hard to not only schedule patients, but schedule our time as well. And we're always pressed to, can't you see another patient? Okay, we're already scheduling 4 to 5 people an hour now. You're asking us to do more, and if they all show up, everybody's unhappy. But Erie is a fairly conservative community. We have 2 Catholic universities. One is right across the street from us. We cannot do outreach at those universities. However, we have a little under-the-counter referral system with the school nurses, and that works out somewhat, but I would love to be able to get into those schools. And that's about it.
Thank you. Great. You'll all have a chance to talk some more about what you're all doing. And then finally, Brocade, the end there.
Hello. Can you hear me? Maybe a little closer.
Yes.
Yeah, that should be good.
Can you hear me? You're good. Okay. Good morning. I'm just so thankful for being here today and being able to share my community with you. As she said, I'm the maternal child care coordinator, which I was placed in that in January, just to improve our prenatal care, basically, on the Crow Reservation. So my role is to basically follow from the time that they're pregnant to the time that they deliver. And during that process, I just make sure they get their labs, their ultrasound, and just if any needs that they need on the way, and make sure that they keep their prenatal appointments, follow them through that process. And then also I do follow the referral process too of the Women Health that the providers do put in for the referrals. And then also due to labor, we have no labor and delivery at the Croner and Cheyenne Hospital. And so when they hit 30 weeks gestational, they are referred out to Billings, Montana, which is about 60 miles away from the Crow Reservation. And so at that time, I do help them with that process. I keep in touch with them and just give them that support that they need for that referral process. And then after they do deliver, I do give them a call, postpartum call, see how they're doing, how the baby's doing. And so I just really love this job because I feel that bringing a new life into this world is such a blessing, and it's a beautiful thing. And to be part of that, I just love it. So I think I finally found my passion in life. So it's been wonderful. So I was born and raised on a Crow reservation. I myself is Crow, so I have seen how our culture has changed from growing up to now, and I think we're making some pretty big strides in that. The Crow Reservation is the largest reservation in Montana. It's very rural. We have about 5 towns, and so for them to come in and get care, some of them have to travel an hour away, and so there's not many jobs on the reservation. We have no to limited transportation, so it is hard for them to come in and make their appointments. And we do try to work with them. You know, we call them, we reschedule them, we encourage them to come. We really work with appointments. And then also some of our Crow customs, our culture, as far as family planning, we don't really do much of that. In discussion with it, like personally me growing up, I was inquiring about birth control, and my mother was like, let's not talk about that, wait till you're 18, you know, sort of thing. And me growing up, I didn't know that you didn't have to be 18 to get on birth control. So that was just, you know, something personal. So I did wait till I was 18. And so with that, and then also traditionally, we don't buy anything for the baby. When you're pregnant, you wait till after you deliver the baby to buy anything for them. And so we have baby showers after. So that's just how we just a culture that we don't participate in. We're very modest. We cover up. In social gatherings, men and women, they gather to separate areas in a social event. And so there's also that. And then I did discuss with my older coworkers that have been in the health system, and they did see changes as far as like breastfeeding. It was more of we would hide, we'd get away, we wouldn't go on social events or anything, and we're seeing they do breastfeed more in the public now. They do cover up, so that was one of the positive things. And then also she's noticed that with deliveries and prenatal care, it was always the mom and the auntie and the prenatal patient that would show up to appointments. And even in delivery, the dad would be waiting at the door, and the mom and aunties would be in the room with the delivery. But times are changing. We're seeing more of the husbands or significant others coming in the prenatal appointments and being more involved, and also during delivery. They're there too. We are seeing a lot more teenagers coming in to get on birth control, so that's a wonderful thing. I did talk to the public health nurses, and she is allowed to go into the schools and treat their STIs, and she said she does educate them that, you know, our options of birth control and that they can come in. So I thought that was a wonderful thing. As far as initiatives that we're taking at the Crow Hospital, we are currently we are currently trying to reopen the labor and delivery. It's in the process. They've bought all new equipment. They remodeled all the birthing centers, and then of course my maternal child care coordination position. And then they are hiring. They're in the process of hiring OBGYN staffing, and then they're also going to be hiring a director of nursing that has previous OB experience. So I think that'll be a great asset to our reopening of the labor and delivery. And then also, we did recently partnership with the Riverstone Health, which is located in Billings, and we had a Women's Health Day and Health Fair, and they received $15 gift card if they came in and got a Well Women exam and or a mammogram, and so that really worked out well, and we did follow up. And then also, I really thought it was really good that last month we had a all-staff mandatory meeting of trauma-informed care. So it was really awesome to see how trauma played into, you know, our community, and they put that aspect in there. And then we are also able to look at ourselves as healthcare providers and the trauma that we've experienced, and trying to understand our community that we work with. It was really wonderful.
Great.
So,
Well, thank you.
Yeah.
Thank you. Well, I guess you have a sense now of the richness and the diversity of the different places that we included in this study. I wanted to talk a little bit about the social determinants of health. You know, one of the factors that I think came across all of these sites
was really the critical role of the social determinants of health, and particularly in shaping access to reproductive health services. And I wondered, Cachet, if you could tell us a little bit about how that plays out in Selma, Alabama.
Sure. So, as mentioned in the study, Selma has one hospital that delivers babies for about, it stretches from the Mississippi line almost down to Mobile, which each way is about 2 to 3 hours away. So if you're in rural satellite communities and you have those other barriers like transportation, just educating someone telling you that you need to test positive to be pregnant, get blood work done. A lot of times we're seeing moms show up in the end of their first trimester. They're also showing up with chronic diseases that they were not aware that they had, and they may also pass on to that baby. For a long while, since I was at Rural Health for about 2 years, we only had about 2 OBGYNs. There was no time, from their opinion, for preventative care and education, and even some of those GYN services. So where my organization comes in is we handle the annual pap smears, breast exams. We do the preventative, birth control, things of that nature. The health department also plays a role, and they do some of that family planning, but it's always referring. It's no delivering from my health center or the health department. There were 2 OBGYNs, and for about a year, we were down to 1. Recently, we did have a young lady by the name of Shaniqua Brown relocate from South Carolina, and now we're back to 2. One of my rural hospitals in Marengo County, Alabama, they partner with UAB Medical System to try to bring back the delivering service. Not sure when that's going to happen, but since we've expanded down to Monroe and we're working on Clark County, there are 2 other rural hospitals, again, 2.5, almost 3 hours away from my region, that deliver babies in Monroe County, Alabama, and then Grove Hill and Clark. But that's one hospital for the entire county. So it's very important for me as an FQHC to partner and create that continuity of care between the health department, the private practice specialists, and then the hospitals to ensure that that mom and that child receives the care that's required during that process. And I shared with your team that I believe that it's also important to give that mom at least 12 months or so after, so she recovers and she gets the care and services she needs after. Being a mom of 4, that's very important, because after that postpartum delivery visit at 6 weeks, then you're left to see that doctor, in the next, 8-9 months for your annual. In between that time, you go through so many traumatic experiences, especially if you're considering breastfeeding. I breastfed all 4 of my children until they were 2. There are a lot of emotional and mental things that went along with it. The stigmas of doing it in public, being able to pump at work, working around individuals that don't understand your commitment, the care of providing that nourishment to your children at a daycare facility, just education around it, it's lacking. But the 2 OBGYNs in Selma, they're open to partnering with us and providing that family planning, education, and parenting classes across our health systems. And our goal is to do that with the other 2 rural hospitals as well.
Great. Katie, Dr. Plex, could you tell us a little bit about St. Louis? As Usha alluded to a study that really highlighted some really, I thought, staggering disparities by zip code in the St. Louis region.
So I mean, the social determinants of health play out in our patients' lives every single day. Poverty is really detrimental to health. Racism is really detrimental to health. Not having access to quality education, really detrimental to health. I think when people are just trying to survive, then and keep a roof over their heads, it is not uncommon, and this was quoted in the study, is that people will trade. So they will trade sex for a roof over their head. They will trade sex for transportation. They will trade sex for food. And this is really just people trying to get by and not have to sleep on the street. So these are the young people that we see. And, you know, I think when they do come, then we're just trying to really do everything we can in that moment to try and alleviate really the suffering. So you know, St. Louis St. Louis was south of the Mason-Dixon line, but it was a border state, as you all know, so it has this very interesting history. There is a street called Del Mar. North of Del Mar is largely been the African-American community. It is seen major disinvestment of a lot of public infrastructure. And, you know, 50 years ago, there was Homer G. Phillips Hospital. It was one of the premier training sites for African-American folks who wanted to become doctors and nurses and healthcare workers. It closed very dramatically in the middle of the night with patients being wheeled out. I'm embarrassed to say probably about 30 to 35 years ago. And so this history, like in other communities that are demonstrated in the report, really plays out in how people interact with healthcare, how they trust healthcare, the information we give them, in addition to all the social determinants of health that those divides create. So there's a lot going on that takes a lot of different people besides just healthcare providers to help people.
Thank you. I'm going to turn now to another issue that you alluded to as well, which is Medicaid expansion. In Alabama and Missouri, if a new mom earns more than, I think it's around $4,500 a year for a family of three, she personally is not eligible any longer for Medicaid, even though she may be covered for her pregnancy. She likely will be covered for her pregnant, although her infant is covered for the full year. And, you know, you talked a little bit about some of the issues that women need, you know, the services that women need postpartum. We heard a lot when I went to the Selma visit as well about the gaps. So many of the women were uninsured, and so many of them actually relied on the Title X program and the Medicaid program there. I wondered, you know, and this kind of takes us to another place, which is Title X, which has really been kind of the foundation for a lot of women, along with Medicaid. And I wanted to turn to Susan a little bit to talk about some of the Title X changes. As many of you know, recently the Trump administration made changes to the program that now bans referrals to abortion providers and also requires that all clinics, in addition to having financial separation, I'm about to start coughing, also have full physical separation as of March 2020. As many of you know, Planned Parenthood has withdrawn from the program, as well as many Title X grantees and providers. Our own work shows at Kaiser that about 25% of the sites actually have withdrawn from the program. So I wondered, Susan, you're a Title X provider in Pennsylvania. I wondered if you could talk a little bit about how you've seen this play out in your community there.
Certainly, it was quite a shock for us as providers to read the new regulations and actually have policies sent down from our central office about how we have to change the way we do things. Prior to the changes, we would have maybe 3 or 4 phone calls a week asking for information about abortion providers. Our organization has never provided abortions, and there are no providers in the city of Erie. So we had made referrals. We would give them information about the providers in Pittsburgh, Pennsylvania, Cleveland, Ohio, and Buffalo, New York. Also, patients would come in for pregnancy testing, and we would be able to give them a list of all of the providers, general cost, what they could expect. And in doing so, we gained trust, and these women often return to us for postpartum care or for post-abortion care. Now, if they call, when they call and ask for abortion information, do we have information? We have to say no. And if they come in for a pregnancy test and request information, they do need to see a nurse practitioner. We can discuss all of the options, but we have to, of course, as we always have, provide all the options. And we now give them a list of OBGYN providers. Hidden in there is, the abortion provider in Pittsburgh, but we're not allowed to point out that this is where they call. It's up to them to call, on their own to call the different people. It really is a gag rule, and it's very uncomfortable. We don't feel like we're giving proper care and education to women in a difficult time of their life. The other change has been with minors. We now are required to ask and document the ages of their partners. And this is something we have never, ever done before. The first thing that we tell these young women is that everything that happens in this room is confidential. We don't share information about you with anybody. And in the second breath now, we have to say, and I say it basically this way, I am required to ask you the ages of your partner or partners. And it's, it's demeaning to them. It's demeaning to us. It's, we have always, when there was suspicion of coercion or abuse, we would definitely delve into, what the relationships were like. And we have, reported to Children's Services at times. However, just the across the board questioning, it makes, it goes against everything I ever learned as a professional and how to treat young women with respect.
Thank you. I wonder, Dr. Plax, if you could comment a little bit. And I don't know that you're a Title X provider, but certainly this issue and around particularly Planned Parenthood's role in Missouri has been something I'm sure you're...
I think Susan described it incredibly well, the issues with the changes in Title X. We are not a Title X provider, and right now I'm breathing a sigh of relief about that. I think the Planned Parenthood in St. Louis, I think actually it was a national decision, that because of these kinds of rules and bringing those rules into the exam room just really felt like an incredible clash with the values of providing affirming, positive, respectful health care. And I think that's what you so beautifully described. Thank you for sharing that with us. I think in some ways, because of everything going on in the country, these rules didn't get fully recognized for the devastating consequences to women and actually, frankly, to everybody seeking Title X services, but also to the health providers. It's really devastating to feel that you're not living up to the ethical code of conduct that you pledged to, and that was really deep and profound and important to your profession, and what you went out to train in that profession to be. And I think that part of this story, and that's why I so appreciate Susan sharing that story, got missed. So I will feel like, I will say in the last few years, I've never felt more intruded in my exam room conversations. And in Missouri, there are so many rules about what can and cannot go on. And, just the deep and profound loss that this creates for the ethics of our profession.
Great, thank you. Now I want to shift gears a little bit and really talk about an issue that affects millions of women in the United States, and that's intimate partner violence. Katie Meter, in your work, you confront, I think, some of the most difficult situations that women really face in their lives. Also, many of the women in your community are undocumented, so they may be even more reluctant to seek help. Can you tell me a little bit more about the women you serve, the challenges you face, and also the program that you established with law enforcement there? Yeah.
Sure. So as I mentioned, Tulare County, we see rates of domestic violence that are significantly higher than other urban areas of California. There's a lot of factors related to that, but we have also seen an increase, as I think is true probably across much of California, but an increase in domestic violence related homicides and deaths. So in 1 year in our community, we had 11 domestic violence related deaths, which did include, we had 3 offenders that died by suicide following the murder of their partner. And so those rates are extremely high for our per capita. And so as we are one of only 2 domestic violence shelters in our entire county, we were really looking for a way to affect that number and recognizing that because of our sort of a little bit of distance from the government as far as being a social service provider. We're not part of the county infrastructure, that we had an opportunity to engage women in those situations before their domestic violence escalated to a lethal level. And so partnering with the Jeannie Geiger Crisis Center, which is actually based in Massachusetts, as well as using the research of Dr. Jackie Campbell, who's out of Johns Hopkins, about intimate partner-related homicides, we formed a domestic violence high-risk team, which is a collaborative, and really to get anything done in our community has to be collaborative, just because of stretched resources across our big geographic region. But so we've partnered with law enforcement, probation, ourselves, and our district attorney's office so now that every domestic violence call that our sheriff's office goes out on, they actually are doing an evidence-based risk assessment to evaluate which of those situations might be escalating toward a lethal event of domestic violence. One of the risk factors is pregnancy, and we do see that as a significant part of the conversations that we're having with women around domestic violence and the intersection with their health and their raising of children. And so if those cases screen in as high risk, we actually review them as a team. We put together intervention plans for both the survivor and the offender, trying to work with those who harm as well. And since we've implemented that, we've had over 500 cases reviewed. And we, in the first year following our launch, we had 0 domestic violence related deaths in our community. So, and we saw an increase. We know the research shows only about 4% of women who are ultimately killed by their partner actually accessed a shelter or provider like ourselves, but a significant amount of them are engaged in the healthcare system or in our criminal justice system. So we know which cases these are. We're just not getting those people connected to advocacy-based services, which is what we're trying to do. And only about 4% of the time are they actually accessing that in the year prior to the murder. This year, when we were able to implement that project, we saw almost 40% of the women contacted get engaged with an advocacy-based service. So we do see that those collaborations are really important to getting work done. And we do know these are primarily women who are often afraid to come into the system for whatever reason. We're seeing that for sure with our shelter. A lot of women calling, especially those who identify as Hispanic or Latino, and where they want information, but they won't necessarily come in to access services. So we're having to get more and more creative about how we can engage folks that want to achieve that safety. So that's what we're doing.
Great, thank you. Does anybody else want to comment on issues of intimate partner violence that they're facing in their community or services? No? Okay. That's a big one. I think it's a big one. I think we're all, I think programs like yours are so important because I do think that our providers are really at a loss, and now, being part of other work that, recommends providers do screening in a
Right.
clinical setting, that's so important. But then kind of taking that next step is, I think, really, really hard. And I think sometimes in small communities, I just wonder where everybody kind of really knows each other, it becomes very challenging.
Well, and I feel like we have to, even though we're a victim service provider, we do have to try to be more of a case management role for our folks because health and social services are limited in our community. We do have a Planned Parenthood in Visalia. There's one in our entire county, and they're open 3 days a week for 4 hours a day. And they see, I think, 2,500 patients at any given time. So it is a challenge to get people connected to resources, and we want to especially identify those vulnerable populations of women. I was thinking about an example. We had because something that we're seeing a lot of right now with the women we're working with is reproductive coercion. And so we've actually started screening for that, both through the shelter and through our other contacts with survivors. We had a woman come into our facility with 8 children. I think she was 27 and had 8 children and had been with her partner for a long period of time, had essentially been pregnant for a very long time straight, but was in a very abusive situation and was had finally sort of come to terms with the fact that every time she was attempting to leave her partner, she ended up pregnant again. And so in a vulnerable place where she needed to rely on him economically. And it was discovered that he was actually sabotaging her birth control in order to create that dependency and keep her, controlled in this situation. So we do see those cases quite a bit.
You had something you wanted to add?
Sure. So, like you mentioned, you wonder where did the resources or people go in rural communities. In Dallas County, just speaking for the entire county, I think there's one group called Alethea House. Now, that foundation is based in Birmingham, Alabama, which is more of a metropolitan area, about 2.5 hours away from Selma. So typically, if we get a patient that comes in and she speaks to our social worker or counselor about one of these types of situations, it's a wait time before someone in that local Selma office can actually admit them, document, and try to connect her or him to resources. So people typically turn to churches or they're silent, especially in the school systems. We see a lot of bullying, a lot of young girls and boys that are in relationships and where they're not agreeing and committing to some of the things that are going on, but the peer pressure of, I want to be liked, I want to be accepted is going on, and with a lack of counseling and licensed clinical counselors in the state, that access to those resources are not there. So one of the things that we're working with 2 school systems now, Sumter and Perry County, bringing school-based programs there and focusing on the counseling, behavioral issues, and assisting that guidance counselor in the school system with identifying obesity, depression, anxiety, suicide, drug addiction, and other serious situations that are going unnoticed by families in those school systems.
Thank you. All right, I see the time is passing quickly. I have questions, lots of questions, but I do want to turn now to abortion access. So with the exception of St. Louis, which now houses the only abortion clinic in the entire state of Missouri, at least for now, you all live in communities where women have to travel significant distances to get an abortion, and even in states like California, as we were saying, where you have generally supportive policies, there are factors that can make access to abortion extremely difficult. We heard about stigma, we heard about a lot of the regulations, you touched on that as well, Dr. Plax. I'd like to hear from some of you about, what is abortion access like and what do women do in your community? Cachet, Alabama, I'm sorry to make you a poster child here, but Alabama passed a law that effectively outlaws abortion. in the state, which is now blocked, although a lot of women we heard actually thought abortion was already illegal in Alabama. And we actually heard a lot strong opposition to abortion from women in the focus group as well that we spoke to, although two of them admitted that they had had abortion, so they recognized that there was a need for women to have abortion services. How does that play out for women in Selma? Where do they go? And
Sure. So I think when your team was there, we were trying to identify the physical building that we assumed the services may have been provided. And
For abortion
For,
services.
yeah,
The
abortion
safe harbor,
services.
yes.
And I think you all did have an opportunity of speaking to someone, right?
at Safe Harbor,
I'm not sure, but.
yeah, I think we
Okay.
may have, yeah. We spoke,
Okay.
no, but you're talking about
The Safe Harbor, yeah.
The Pregnancy Crisis Center.
So I don't believe anyone in Selma actually knows that at the time before this was passed, that you would have to travel to Montgomery, Birmingham, Mobile, wherever those other parent planning or facilities were. Again, if you can't get primary health care because of the distance, because of the transportation, because of the cost, this is not an option for someone who's indigent or afraid to get support. So several women typically have children, and what I don't think lawmakers understand is the traumatic experience of not being able to make a decision as a human puts on a person, and how that's going to affect that child's life and that woman's life moving forward after the baby's there. So I think it's a very unhumane decision to make for a person, because every human being should have the opportunity to make a choice for their life, and at least the life of that future child. So we have a lot of patients that we also have to kind of point. We used to be able to point where to go, and now that's not even an option for them. So we're focusing more on behavioral mental health, helping prepare them for what's to come. So.
Thank you. We'll just kind of go down the line a little bit here. So in California?
Yeah,
the
well,
blue
California,
state, yeah.
very blue state, but we're a very red county. And so we don't have an abortion provider in Tulare County unless there's private OBGYNs that would do that, but certainly not advertised. And that would, of course, require coverage. But the closest provider would be in Fresno, which is about an hour's drive. It can be done on bus. It does take the majority of the day, though. So many of the women that we're working with wouldn't be able to access that option without someone with a vehicle who's willing to go and take them. We're not Title 10, so we tell people whatever we want. Just kidding. But I mean, we really do, as an agency that believes in empowerment, we want to give women whatever information they're requesting access to. So that's really the role that we play, and we've seen things go both ways. But in our community, the King's Tulare Right to Life, which is a big organization where we're from, actually does a lot of the sex education in our school districts. So they still have a significant presence, and that really does impact abortion access. So on the drive that you make from Visalia, where I'm based, to Fresno, where the closest provider is, I think you see about a half a dozen billboards. It's pretty intense. So it is a challenge. And there are typically protests outside of those offices, making it pretty uncomfortable for people to access that as an option.
So, yes, St. Louis has an abortion provider. However, the laws and regulations around abortion in Missouri are really quite remarkable. So one is a 72-hour waiting period, and another is that it must be a physician who does your consent when you come in and must do the procedure 72 hours later, and it has to be the same person. So another is requirements for parental consent if it's a young person. And there are a lot of very restrictive licensing provisions about how close a provider needs to be to a hospital. This is currently in the courts in Missouri. And then the legislator passed this rule this year saying no abortions after 8 weeks and no exceptions for rape or incest. While we do the number of providers has gone down from 12 to I believe it's currently now 3. One thing that I often say, and if you're going, while St. Louis is right on the Mississippi River, if you cross the river to Illinois, like all those rules don't exist. So I describe our situation as we currently have an underground railroad for abortion services, and I'm not kidding. So many people will cross the river because they can get same-day services. And if you're low income and you want to take one day off of work, you're going to do that if you can. Because you can get it done that day and then go back about your business and not worry about that 3-day waiting period. So the one thing about this, though, that's very interesting is as a provider, if you refer somebody to Illinois, you have to pass out this handbook, which the very first sentence written in pink is that conception, I think it's conception is when life begins. There's tons of medical information in this handbook. So that is, now required in Missouri. So that's what so while we do have that in St. Louis, just all the ramifications of all these very restrictive rules really impact access as well as how people feel when they seek out those services. We also have protesters every single day. That's a given.
Wow. Well, thank you. Did you want to add something?
Yeah, just
Susan?
very quickly, I'd like to, because I previously told you what it was like in Erie, but I'd like to highlight the presence of the numerous crisis pregnancy centers we have in Erie and the role that they play. They are very glitzy offices. They advertise for free pregnancy tests and ultrasounds. And the counselors are often people, of course, who've had traumatic abortion experiences and certainly share that. And the goal, of course, is to keep the pregnancy or adopt the baby out. But what they don't tell these people when they come in for an ultrasound is that they're not prenatal care providers. We had one patient that up until 8.5 months was going into the crisis pregnancy center for her blood pressure check and an ultrasound, and she thought that was prenatal care until she asked who was going to be doing the delivery, and then it's like, oh, well, I guess we better call Adagio Health. So in the conservative, Catholic, and evangelical community, this organization is one of the top 10 donation recipients in our county. There are that many people that donate and support these groups.
Great, thank you. I have a question here now for Brocade, which thanks you for the information you provided. And they wanted to hear a little bit more about access to the postpartum visit on the reservation, and if women have to travel 60 miles to Billings. I think that just kind of before it gets started, that this kind of the whole sweep of all of these issues really from family planning, STI services, maternity care, abortion services, we kind of tend to talk about them in boxes, and I'm kind of I'm stuck here with I have this question and this, but for women, they're all part of all of the spectrum of services that they need at different times of their lives. And I think, I think we're all kind of working towards building a holistic system, but I think that we're still a lot of the policies and also our community's misbeliefs and stigma, I think often kind of work against us. So, just the postpartum, I think, is another area where it's just kind of feels like a throwaway, but it's the pathway just what so many women need, so.
Yes, with the postpartum, when I call them, I do assess to see if they do have an appointment lined up where they delivered in Billings, which is
Yeah.
either Billings or St. B's. Some of them do, some of them would like to come back to Crow, so we do get that scheduled that day, and some of them do have to travel about 60 miles. Some of the other towns are closer to Crow, Crow Agency, where the hospital is located. So that's kind of our process there, and I do continue to check on them to see if they made their appointment, and if they didn't, I ask them if they want to schedule an appointment here and follow up. And I also encourage, birth control, see if they started birth control before they left after they had the baby from the hospital. And so just those things, I do try to follow up with them and see if they did get their appointment done. And some choose to stay in Billings, some come back. So that's just our routine, yeah.
Great. And then this, I think, is kind of open to all of them. They say all of the 5 states have Medicaid family planning expansions, have a Medicaid family planning expansion. I guess in Missouri, it's a little different because it's a state-only program, basically, I think, to exclude family planning providers that also offer abortion services. But even in states that haven't, in Alabama, you have a family planning program. Do you feel like this has expanded and helped access to women? Can some of you speak to the role that you've seen that in your states?
Well, generally, I'll say I'll take anything that helps offer people coverage, but it's far from ideal. It's, I will just say, so Missouri's had the steepest drop in the country for children on Medicaid, and also I think for our state-run family planning program. There is systemic work to make systems unworkable for poor people in Missouri, and so the drops have just been incredible, and often without the person knowing that they've been dropped. And so what this means is people show up, they think their visit is going to be covered, and then they're told, you don't have this anymore. And then that creates a whole, a lot of stress and just like, oh my gosh, I just took that day off of work. I was trying to get my birth control done, and now here I am, and I don't have the coverage, and I don't have the out-of-pocket, and I'm stuck again, and I'm done, right? And then to start it all over again. When it is available and people use it, I think it's great that people can get access to contraception, but it is a very imperfect system.
Yeah. Did you have?
I was going to add, so across all of my counties that I serve, I've noticed that a lot of the health departments, the hours are limited, the provider is limited. So my primary care association across the state, we are exploring the opportunity of doing an RFP for family planning services across the health centers, because a lot of the OBGYN offices, they're busy doing procedures and prenatal care. So that preventative care is not actually taking place because the prenatal care is primary at the time. So in Selma, both of my OBGYNs say the cost of the IUDs, the birth control, is very expensive. So to keep it stocked and in the clinic, it's not producing revenue, and if you're not doing the preventative care visits, then it's a loss. Well, it's a loss to the community then as well, because you're not offering that service. So we are partnering to see how can we offer that service and have those OBGYNs to work across our clinics, or the 3 closest ones, on Fridays for half days, or on Saturdays for extended hours, to at least try to fill in that gap, and hopefully it'll allow, it'll limit the number of pregnancies that we're having in our teens, to give them options and choices if they're going to choose to be active with having those services.
Great, well, thank you. I want to close with the voices of women a little bit, and kind of looking a little forward. We asked each of the focus groups of women at the end, what do they feel were important elements of their reproductive care? And we heard things like simple, comfortable, nurturing, affordable, and respectful. And so just really quickly, what do you see are the elements that your communities, what kind of things that you would need to make this a reality? I know that you were all trying to do this in your own healthcare settings, but clearly we hear that this is not the case for everyone. So finally, kind of in closing.
I think collaboration is key. Identifying the medical physicians, the outreach organizations, funders that are willing to make this more accessible to the women in the community is going to what it's going to take for my community. Having it in a centralized location and then partnering with the different programs throughout the county where those women need these services the most. So centralizing it for them and working together, because having it hidden or in different areas continues to create that lack of access.
Thank you.
I think for us, making things more accessible and more respectful are really what we want to see continue to grow. I think our FQHCs in Tulare County have done a great job of expanding out into many of the rural communities that might not otherwise have easy access to even a clinic. But I think we still have more to do with regards to respecting culture, respecting language access. While Spanish is very prominent and pretty well integrated into our service system, other languages are not. And so I think we have some other populations that are being underserved with sort of compassionate and culturally relevant care.
I'll say two things. One is that walk-in, free, accessible. When you come in the door, we consider you our young people, and we treat you as such. And I also just want to say, I think when that happens, there are such incredible moments of joy. And I feel like I want to just highlight two joyful moments. So one is every year we have a spot Thanksgiving. And it's a potluck, and we just welcome anybody who's received services at the spot for Thanksgiving. It is like the highlight of my year. I love this Thanksgiving. Like, people are so grateful to have a Thanksgiving, and it really like hits home to me as like what the holiday is really about. And all of our staff cook for the potluck, and it's just really fun. The other thing I just want to say about the work that we do and why I think those words that the women talked about are so important is that, it is so joyful to watch people go and live their best lives. I have many patients come back. This week I had a nursing student come back, show me her graduation picture, and told me she got her first job because she had contraception and could manage actually the other parts of her life to go live her best path. I had another guy come back. I do primary care for folks with HIV, came back, told me on Thursday, today, he's celebrating a year of being clean. And so we can all celebrate with him today. But there are so many moments like that where people come back and tell me what the kind of services that all the people at this desk do every day, what it means to them, and their ability to live their best lives. And that actually will fulfill me for a lifetime.
Great, thanks.
I can't say any more after that.
Yeah, that's a hard one to follow.
I think I'm really proud to say that our organization really strives to make the kind of care that you mentioned. The difficulty that I see is that it's a grind. It's a daily grind. And to get the information out there that we are there for all kinds of people, the refugees, our LGBTQ people and transgender and refugees, and we're just seeing patients. So the funding isn't there to do the outreach, and that's what I see as a barrier. But those joyful moments are wonderful, and every day when I think that I maybe should retire soon, I can't. It's very difficult to think that I won't be involved in people's lives. The teenagers, the people you can compliment. Say one nice thing about the man or woman who comes in every day that makes me feel good, and I know it makes them feel good as well.
Brocade, you have the last word.
I think the biggest barrier for us is transportation because we're in a huge like rural area, and so that really hinders our ability to reach out to our community. And so I think just when we get them in the door, we coordinate with every other department, try to get the appointments on the same day because we know it's so hard to come in that day, and we try to get everything we can do, the Wild Women exam, we try to get the ultrasound done that day because you never know, once they leave the door, we never know when we're going to see them again. And so that's something that we've added, and I think it's been helping tremendously. And so we do try to help with the whole transportation thing. And just to add, I think these phone calls that I make have really helped the community because when I call them after they have their baby, they're like, thanks for calling. I really appreciate someone checking on me and just asking me how I'm doing because it's a huge transition. You're adding, another baby to the family, and some are new mothers, and so I'm able to help them with that process. So it just really makes my day better, and it helps the community too. So I just want to say thank you for listening to us today, and appreciate it.
Thank you. Yeah, the power of acknowledgement I've learned, is really just so potent. People need to be noticed. You are standing here, you are there, and we're here for you. Well, I have really enjoyed this discussion. We're a little bit over, and I know I'm going to get yelled at, but I'm glad we took this little extra time. Thank you all to an amazing panel today. I hope you've enjoyed this discussion as much as I have. And to Usha and our team of collaborators, thank you so much, and thank you to all of you. And although it's not quite as interesting as seeing all of our speakers here, there are a lot of materials that we've produced for this, a lot of great information that are part of the summary report and also the case study reports, and I really encourage you to check them out. Thank you.